Welcome to the Advances in Research and Innovation stream at SNOMED CT Expo 2025. Thanks to Daedalus for sponsoring this stream. My name is Yongshen Gao, and I'm a senior technologist at SNOMED International. I will be your moderator today for this session. We will address all questions at the end of the presentation. For online audience, please use the QA button to submit your questions to the presenter. For those attending in the room, please feel free to use a microphone in the room and when the time comes. It's now my pleasure to introduce Gavin Jamie from Nuffield Department of Primary Health Care Services, University of Oxford, who will be presenting surveillance of acute respiratory infection using SNOMED CT expression in expression constraint language with routinely collected primary care data in England. Gavin, over to you.
Yeah, thank you very much, and yes, good afternoon. You can tell our title is written by people used to writing research papers. I'm a GP, have been for 25 years, came relatively late into academic in sort of 2 or 3 years ago. And sort of working in the Research and Surveillance Centre in Oxford, where it currently is. It's been around for a while. We've been doing some data collection for getting on for 60 years now. We've been doing a bit of sentinel surveillance and started doing virology testing in 1993. That became all year round because virology testing for respiratory diseases suddenly became terribly popular in 2020. And that was the time that we increased our member practices. So we have roughly 2,000 practices, about 2,200 now, it's gone up a little bit, covering roughly a third of the country in England. If you know UK geography, you'll see England there, and that's roughly a map of where people live in England. So we're pretty representative. And we're getting near real-time reporting on this. So we get an inflow from practices about once a week, sometimes twice a week, if we're doing a bit more intervention. And we're looking for key factors, particularly around respiratory disease. So if people are coding influenza-like illness in practice records, we know virologically, if we do swabs, roughly 50% of them are going to be confirmed flu. And this is much faster than dealing with swab results because we have this really within a couple of days. One of the things our director likes to point out is back in the swine flu epidemic, just about pandemic in 2010, we actually saw a signal in the summer. We're coming through before we had any sign of virology swabbing. We're particularly interested in RSV at the moment because we're actually getting immunisations really for the first year in England. Just a quick introduction to primary care in the UK. We have our National Health Service. Every patient pretty much is registered with a general practitioner, and each patient only has one general practitioner. So we have a record that is pretty nearly a single source of truth. Information from secondary care gets fed back to the general practitioners, as does from other sources as well. Computerized medical records are universal since really at least 2004, which is about the point where we started paying GPs based on some of the coded results in the systems. Nothing increases coding better than putting people's income based on it. I mean, that proved a sort of huge change around there and actually drove a move away from paper notes at the time. And we've used SNOMED since 2018. Before that, we used read codes. I had the James Reed Memorial Lecture this morning. So he was the man who invented the read codes. Then they all got mapped, including historical read codes. Everything was mapped to SNOMED CT in 2018 with a couple of little wrinkles I'll come to later. So we have a complete history coded in SNOMED for patients. Additionally, actually, if you travel between practices in the UK, your record now follows you and stays coded in that as well. That took about 10 years to get working. So where do we get our data from? Well, there are two main suppliers we use, a company called EMIS Web, currently owned by Optum from the US. They just bought them there, so they've got that, and we get a pretty direct ingression from them. It comes through a system called EXA, which is owned by the same people as EMIS, but we also have a third-party data broker called Magentus, which also brings it through. As you can see, we can get data through two routes, so we have to do a bit of deduplication at that point. System 1 still uses the final version of read code, CTV3. That's where the CT in SNOMED CT comes from, because that was an integration of CTV3 with SNOMED RT back in the day. So there is a map there. CTV3 has not been officially updated since about 2018, but we're actually having, so the supplier is sort of patching that together as time goes on. So we get that at least twice a week. The data model is unsophisticated, I think we'll put it that way. We have clinical data, which is a sort of fire hose of SNOMED concepts. We don't have any form of post-coordination really on there, not even left, right, or anything like that, unless it's coded in the data. We have prescription data, which is coded using the UK Dictionary of Medicines and Devices, which is not quite the same at the moment as the SNOMED drug dictionary, but is getting there. And then we get a bit of metadata, including data registration, death, sometimes the region that they're in there, and helpfully a household identifier, because actually all this data is pseudonymized as it's coming in. So we don't, when I say date of birth, we don't actually use anything more detailed than the month of birth, just to try and preserve some anonymity in there, although it's all within a secure data environment, so none of this data gets out anyway. And what do we do with it? Well, I'll start with our outputs there. So this is our weekly reports. So this is acute respiratory infections. This is as of a couple of weeks ago, just when I had to submit the slides. The things have progressed, as you might expect, since then, and it's gone up on there. But we have about sort of 50 of these graphs. Just one more I found interesting was actually we're seeing COVID. We're having a bit of a resurgence in the UK. That sort of brown line that's going up to meet the blue one, that is our over 65s that we worry about a bit. I'm pleased to say that's actually flattened off on the report from yesterday, but we were able to give that report fairly quickly. Combined with virology reports, as of yesterday, we were seeing an increase in influenza, but our vaccination campaigns both started for flu and for COVID and influenza both started at the start of October. So hopefully that's going to carry on to be flattened. So we actually drilled down in our reports. We have our own sort of internal ontology, which we use there. So acute respiratory infection, you saw, is sort of right at the top there, but we can drill down to these. To influenza-like illness is pretty much a thing on its own, but we're looking at exacerbations of chronic lung disease, upper and lower respiratory tract infections, and the sort of not otherwise specified down the end, because GPs may be coding just as an acute respiratory infection there. So we have to have that NOS. We're bringing in a sort of ICD concept on there. We've also sort of pushed suspected COVID into that area as well, although as you can see, we are reporting it separately. I'm going to define a couple of terms here which are not particularly well defined in the literature. So primarily it's talking about value sets, which is just that list of SNOMED concepts. Value set is the fire terminology for it. In SNOMED CT, we're quite often referring to them as ref sets. They're functionally equivalent. There's a lot about the structure and the metadata that differs between them, but we've tended to settle on value set as our word. And the phenotype in that wordy definition is really we're taking these value sets and we're trying to create a fingerprint for illness around there. So in the case of acute respiratory infection, if you've got 2 codes within 2 weeks, we tend to assume that's 1 episode of illness. So we're wrapping a little bit of logic around that. And by the time you're doing a phenotype, you're also going to define which patients you're looking at over which time scale. So that was the phenotype library's description of it. And we're much better at defining in SNOMED CT the value sets than phenotypes. Phenotype libraries have a rather mixed provenance on that. So how are we defining our value sets? Well, we've got 2 ways of doing it. We have our intentional, so we're describing it algorithmically. So for something like diabetes, we might say we want the diabetes SNOMED concept and everything underneath it. It's much faster and easier to maintain. It's much easier when we're producing weekly reports because we don't want to have to revisit our value sets every week. And generally, when a new version of SNOMED comes out, we've got the UK edition, comes out twice a year. We don't have to go back and we have to have a little look over just to make sure if anything's changed, and we can automate that as well. Extensional is those static lists. It's much easier to deal with. You can put it in an Excel spreadsheet with some care. I don't know. Presumably most people have put SNOMED into an Excel spreadsheet. So, yeah. So yes, formatting as text is the number of rounded spreadsheets I've had this over time. And you can use it without access to a terminology server. So just, I suspect with this, everyone's sort of familiar with the hierarchy of SNOMED. So we have that is a hierarchy all the way down, so we can define a respiratory tract infection and we get everything down to bronchopneumonia. Of course, it's not that simple because we have all sorts of other things coming off and on there. So we have that poly hierarchy. Skip through there. So we have our authoring tool. I'm not going to, because you can't read this really. So we're able to define our supersets, so that's anything in green. So we've got infectious diseases of the lung here because we're trying to define pneumonia. But also we can remove things. We're taking away these sort of minus supertypes. So that would include things like chronic disease and things. And actually we've got a block of these we're pretty much using at quite a high level to remove chronic disease or some of the other things that are not going to be sort of acute pneumonias for our purposes. And we can get down into the light sort of cyan and magenta. We're sort of removing or adding individual codes. So just to see that sort of in a sort of more graphical thing, we have a sort of big green. We're taking everything down there, so that's going. So we're adding everything underneath, but we can exclude things using that minus supertype. We're excluding everything in that in the lower part of the hierarchy. But we can do individual concepts as well, so we can put in these black blobs or remove the black blobs as we need to. And that works fairly well. And we can express it in machine readable. I don't expect anyone to be able to read this, but this is nice, this is transferable. We have many terminology server vendors on the floor here, and you can put this into pretty much any of them, and you'll be able to get it out there. We have so both things that are in the international edition, or the sort of rather longer ones. There's some UK edition codes in there as well, which makes it not quite transferable, but if you're moving it to another edition, then you probably, this is not a bad place to start. You can have the long form, which is, I was going to say more readable. I'm not remotely convinced it is actually when I put it on the slide, but at least it puts the description on there. So at the top we've got influenza, and then we have everything from around about there, about halfway down, is the minuses we're taking out there. So we're taking away parasitic disease and chronic disease and things. So we've got that. We've got a transferable, we've got transferable expression for just demonstrating our value sets. But we have an issue. We have inactive concepts. And because we're looking back over such a long time, we have many inactive concepts. This is slightly less of a problem in surveillance, but we can have things that have been mapped across, and we have sort of historical things. So inactive concepts will be removed from new entry, but they remain in the clinical record. They lose most of their SNOMED definitional characteristics. Is a characteristic we saw earlier is supposed to become a was-a. I don't find that reliable. I don't find that helpful. But we do also, it does come with a ref set which gives the reason for removal and whether it's been an ambiguous concept. And we get suggestions for replacement, which we use. So we've got possibilities for replacing the concept, because we really don't like having inactive concepts in our definitions. It doesn't work in that hierarchy because that is a characteristics have disappeared. So we've got, some of the definitions are really easy. So at the top we've got flu-like illness, NOS, is the same as flu-like illness, NOS. Well, that's fine. We can cope with that. It's been a tweak in the namespaces. We can find that things get replaced by other things. Well, that's reasonably easy to deal with, and we can do that as well. And note that we're actually going to be doing this backwards, because we want to take the active concept and find the inactive ones. So we're going against the direction the map is expecting to work. We get things that get a little more difficult sort of further down. So gastroenteritis due to avian influenza is possibly gastroenteritis caused by influenza A, which is certainly a sort of super type of there. But if you're particularly wanting avian influenza on your searches, you're going to find much more by going on there. And then we get onto the possibly equivalent to, which is possibly equivalent to two different things. And if we're doing that backwards, then we start to sort of pull in other concepts. So if we're looking for non-infective pneumonias, how do we search for that in the future just using active concepts? Well, we can't just pick pneumonia because we'll pick all the infective ones as well. So we generally have to think a bit more about them. We can do this automatically through our expression constraint language. We put a history mod on there. So we're trying to use these, so the map is designed to work forwards. And there's a couple of more things that are vague and reverse. So if we've got left eye background diabetic retinopathy is possibly equivalent to these other things. Well, that's sort of interesting because perhaps we might be trying to find type 1 diabetes, and we might have picked up one of those type 1 codes there. And if we're working backwards from that, then we'll end up picking up left eye background diabetic retinopathy. So using these historic reference sets, particularly in reverse, can be really helpful. It's a real time saving, but you have to be quite clear that we're not sort of picking up codes that are more vague. Once we have these, we're starting to look at how we can publish them, because we're particularly interested in open science. We're an academic organization. We are largely paid for by government, including the UK Health Security Agency. So we want to look at how we publish these. So there is an NHS terminology server. We can take our definitions that we saw earlier. We're putting some metadata in there. The UK uses Onto server, who are again downstairs, and they're showing off their wares. And you can access that directly, or we're actually doing it directly with a FHIR interface. This FHIR interface is a lot simpler than dealing with patient care on there, because you need much less authorization and things, because we're doing a completely separate from patient information. So there's no patient information held on the terminology server. It's simply a useful API. And the nice thing is it forces us to actually look at a bit of metadata for these. We're looking at life cycles. We want to be able to say whether this is a draft or is active or retired. We can add other code systems in there. In theory, you can also mix up code systems, so you can have SNOMED CT alongside ICD-10. Personally, I think that's quite a bad idea. because it's almost impossible to get exactly the same meaning from a SNOMED expression than an ICD-10, and I think it's probably much better having two separate codes so people can understand the difference in the provenance between them. And it's also got a bit of contact information on there. So far we have published 16 value sets. They're currently marked as draft because we are sort of experimenting on the server. We have a bit of a prototype of a web page to display these, which is using that API key earlier. I'm not a coder, so it's a fairly basic web page, and a reasonable amount of it was written by ChatGPT. But certainly that's the direction we wanted to go to. And now we can publish a URL or something similar at the end of papers, so we can share these with the hope of making this not only easier for people wanting to implement in the future, but we have a reproducibility issue in science at the moment, and we want to make that bit easier. Thank you very much.
People in the room, please use the microphone to ask your question so that everyone can hear clearly. Any question here, please? Yeah, go to the microphone.
Hi, Maël Legal from the French NRC. I might have lost you sometimes, but is there any reason why you automatize the history features through the ref set rather than the history feature of the ECL?
We do, well, it's practically done in the ECL, but what the ECL does is it uses that ref set, and you can, in the ECL, adjust the sensitivity, so you can avoid the possibly equivalent to. It's a case of sensitivity versus specificity, really on there. Thanks.
Any more questions?
I have two questions. First, about ECL also. I'm just curious about the decision to query directly on the disorders instead of using just some combination of disorder and attribute and values. So for instance, you could maybe recreate that non-infectious pneumonia, but if you had used not, causative agent, organism, et cetera. That's the first question, maybe.
Yeah, I mean, I think it was originally done for a degree of simplicity, because internally we're actually running off SQL Server, so it's just a transitive closure all the way down. So we are just using that hierarchy. We do use properties when we come to medications. So we'll say something like amoxicillin tablets, and because that's really the only way we can do it there. I think we've, for ease of authoring, I think as well, I think probably when we started, the properties were there were less fully defined concepts and more primitives, and that becomes more difficult to find.
Okay. Just second question, just in general, what's the use of the data with the graphs and everything you showed? What kind of actions will be taken based on the information you gather?
I mean, we do. It's reported through the UK Health Security Agency. That's what used to be Public Health England. So they're doing their weekly reports. There are thresholds to be met for things like use of anti-influenza medications, antivirals as well. We are sort of monitoring disease there. We also do some research. I've been limited to the surveillance here, but at the end of the winter, we'll be looking at vaccine effectiveness. And also, we're doing sort of more general research projects. So we're looking at things like shingles, herpes zoster vaccines, and effect on dementia and things as well at the moment. So we're doing, our primary output is the surveillance, but as I say, we do the research projects alongside.
Okay, that concludes this block of sessions. Thank you, Gavin, for your presentation. To our online delegates, the next group of session will begin at 13:30, basically 1:30 p.m. Local time. You can rejoin via the event lobby. To our on-site delegates, the lunch is now being served in the exhibition hall, and current sessions will resume at same time, local time. This is your last chance to take part in our passport game, if you have not participated, and visit all the exhibitors in the hall. Yeah. Thank you. Thank you very much.